morning everyone. Myself JHANSI from Narayana Medical College. My presentation is on cataract surgery in short eyes including non-ophthalmus, visual outcome, complications and refractive results. Introduction. Cataract surgery is challenging in short eyes with increased complication rates and poorer postoperative refraction predictability. Short eyes include simple microphthalmus, complex microphthalmus, non-ophthalmus and relative anterior microphthalmus. Aim to report the visual outcomes, complication and refractive results of phacoemulsification surgery and IOL implantation in a large series of adult patients with short and non-ophthalmic eyes. Primary objective of the study is to evaluate the visual outcome and complications of phacoemulsification surgery in adult short eyes and non-ophthalmic eyes. And secondary objective is to compare the predictive postoperative refraction in these patients using Barrett Universal 2, half-a-Q, SRKT and Kane formula. Inclusion criteria: normalized with an axial length of less than 21 mm. Exclusion criteria: patient who did not undergo cataract surgery, patients with incomplete medical records or insufficient follow-up, patients with concurrent planned procedures such as vitrectomy or trabeculectomies. Materials and methods: preoperative data collected from each patient included age, gender, axial length, anterior chamber depth, corneal power, previous or current ocular comorbidities, previous ocular surgical procedures, preoperative refraction, spherical equivalent was taken, and preoperative corrected distance visual acuity and IOP is measured. Postoperative data included corrected distance visual acuity, IOP and refraction at 3 months after surgery as well as postoperative complications. And visual outcome was measured in Snellen's chart and converted to logMAR units. The mean numerical error and mean absolute error was calculated. Cataract surgery was performed on 71 eyes. A total of 33 eyes had a history of glaucoma. It is a retrospective study. And my results: median age of 71 is taken and an axial length of 20.48. Corneal power is 45.44 and anterior chamber depth was 2.46. Preoperative corrected distance visual acuity is logMAR 0.48 and preoperative refractive error is plus 4.75. It's a spherical power, and preoperative IOP was 50. Changes in the corrected distance visual acuity at 3 months after surgery. Increase of more than 3 lines is seen in 31 eyes, and increase of 1 to 2 lines in 22 eyes, and no change in 9 eyes, and decrease of 1 to 2 lines in 6 eyes, and decrease of more than 3 lines in 3 eyes. Corrected distance visual acuity before and after 3 months after surgery, and logMAR 0.3 or better. Preoperatively 22 and 3 months postoperatively 47, and logMAR 0.32 to logMAR 1. It is preoperatively 39 and 3 months post-op 20, and logMAR 1 or worse in preoperative 10 and 3 months post-op it is 4. Refractive outcome: based on mean absolute error, SRK by T were significantly more accurate than half-a-Q Barrett Universal 2. Predictive errors for each IOL formula, and mean numerical error it is more significant with SRKT, and mean absolute error is also more significant with SRKT. Eyes within 0.5 diopters of predicted postoperative refraction. With 23 eyes it is 40%, and with half-a-Q it is 12 in 21%, and SRK by T it is in 20 eyes with 35%, and Barrett Universal 2 it is 15 eyes with 26%. Eyes within 1 diopters of predicted postoperative refraction, it is highest with SRKT, and 36 eyes with 62%. Discussion: cataract surgery in short eyes is surgically challenging with a higher risk of intraoperative and postoperative complications, in addition to the increased risk of uveal effusions and an increased risk of aqueous misdirection, CME, and choroidal hemorrhage, vitreous hemorrhage. Eyes is situated deeper in the orbit and often has a poor pupil dilatation, and closer proximity of the iris to the cornea increases the risk of Descemet's folds iris prolapse into the surgical wound. Postoperative refraction is more difficult to predict in short eyes. In our study, SRK by T was significantly more accurate than half-a-Q and Barrett Universal 2 in predicting postoperative refraction when based on both mean numerical error and mean absolute error. The limitations of this study are relatively short follow-up period of 3 months as well as it is a retrospective design. A longer follow-up period would be useful in assessing whether the reduction in IOP following surgery results in the reduced need for glaucoma medications in non-ophthalmic glaucomatous eyes. Conclusion: cataract surgery in short and non-ophthalmic eyes is challenging with a higher complication rate than routine cataract surgery, but frequently results in good visual outcomes. And these are my references. Thank you.